When a medication enters the body, it is immediately swept through the bloodstream, filtered, and broken down. We call this mechanical process pharmacokinetics. It is the sum of absorption, distribution, metabolism, and elimination. The inverse of this relationship is pharmacodynamics. This describes the physiological effects the drug exerts once it successfully binds to the body's target receptors. This graph is a standard pharmacokinetic curve, plotting the concentration of a drug in the blood plasma over time. Notice the highlighted horizontal band across the middle. This is the therapeutic window, the precise margin between a minimum effective dose and a toxic overload. Clinical medicine operates on a baseline assumption. A standardized, weight-based dose is calibrated to land the peak of this curve squarely inside the therapeutic window for the average patient. But give the exact same dose to two different individuals, and the results diverge. One curve resolves safely, while the other spikes violently into toxicity. The average patient is a statistical artifact. Any deviation from the standard clinical response is driven by a complex system of 4 interacting variables acting on the drug simultaneously. Predicting whether a medication will heal or harm requires moving beyond a static dose. We have to map physiological, chemical, environmental, and genetic stressors directly onto the baseline response curve. A patient's biological makeup and baseline physiology are the first variables that distort standard drug absorption. This side-by-side comparison shows age variations in body composition. Pediatrics possess higher total body water, and immature liver enzymes restrict early clearance. The elderly baseline flips this, exhibiting reduced renal clearance, decreased liver blood flow, and higher body fat. For fat-soluble drugs, higher body fat creates a larger biological reservoir. This increased volume of distribution causes the curve to flatten out horizontally, dropping peak concentration. To compensate, doses for lipophilic agents must be calculated on lean body weight rather than total mass. Pregnancy acts as another physiological modifier. Increased plasma volume, accelerated renal filtration, and elevated CYP3A4 enzyme activity rapidly alter the timeline of systemic drug exposure. Treating body mass as a static mathematical input is flawed. Variations in fat, water, and organ maturity directly warp the physical space a drug occupies and the speed at which it moves. If physiology is the biological terrain, the intrinsic properties of the drug molecule determine how it navigates that terrain. Here, a microscopic lipid bilayer membrane models lipophilicity. Fat-soluble molecules pass seamlessly, while water-soluble shapes are repelled. Ionization acts as a secondary gateway. Only unionized fractions cross efficiently, while ionized fractions become trapped, accumulating in surrounding fluid compartments. Physical dimensions act as limiters. Molecules with a high molecular weight or a large polar surface area cannot squeeze through cellular defenses via passive diffusion. Because of these barriers, the route of administration dictates systemic bioavailability. Intravenous delivery bypasses hepatic first-pass metabolism, ensuring 100% absorption. An oral tablet, however, loses a variable fraction of its active compound just surviving the digestive tract and liver. This data model highlights plasma protein binding. When entering the blood, drug molecules bind to large plasma proteins like albumin, becoming biologically inactive. This leaves a severely limited free fraction of unbound molecules available to interact with targeted cellular receptors. A meticulously calculated dose is useless if the molecule's specific chemical structure prevents it from breaching lipid barriers or evading protein binding. Even when the patient's baseline physiology and the drug's chemistry align perfectly, acute disease states and environmental exposures disrupt metabolic homeostasis. In the case of renal failure, a damaged glomerular filtering system severely restricts the body's ability to clear drugs from the blood. Decreased clearance from renal failure increases the drug's biological half-life, stretching the elimination tail outward. Successive doses stack on this uncleared baseline, pushing concentrations into toxicity. Hepatic dysfunction synthesizes less albumin, increasing the free fraction and causing a steep initial concentration spike. Environmental factors, specifically drug-drug and food interactions, act on the cytochrome P450 system, either inducing or inhibiting metabolism. enzyme inducers like heavy smoking accelerate liver metabolism. The resulting curve rapidly plummets below the minimum effective concentration, causing therapeutic failure. Conversely, CYP inhibitors choke metabolic pathways, preventing breakdown and spiking systemic exposure to dangerous toxic levels. Relying on static dosing regimens is dangerous because organ impairment and interacting compounds continuously shift the body's timeline for clearing toxins. The fourth and most critical hidden variable operates at the deep molecular level, the patient's underlying genetic code. Genotypic variation accounts for up to 95% of individual variability in drug response and disposition for specific classes of medication. This variability is largely driven by metabolic polymorphisms, specific genetic mutations in liver enzymes like CYP2D6, CYP2C19, and CYP2C9. These mutations divide patients into classifications. A standard dose produces a toxic spike for poor metabolizers, a standard curve for extensive metabolizers, and a flat line for ultra-rapid metabolizers. But if the mutation is in the target receptor, it leaves a perfectly normal pharmacokinetic curve. Receptive variants alter pharmacodynamic efficacy independent of plasma concentration. Watch the graph. The drug concentration remains static, but the patient's receptors are so sensitive that the therapeutic window itself drops. Physiological clearance was perfect, but the standard dose is now instantly toxic. If a clinician accounts for physiology, drug chemistry, and environmental factors, unmapped genetic variations can still render a standard dose completely ineffective or instantly lethal. Safe and effective medication management requires calculating all four vectors: physiology, drug, environment, and genetics simultaneously. This patient profile dashboard is a predictive analytical model. It tracks physiology, drug properties, environment, and genetics, all surrounding a central pharmacokinetic curve. Let's run a complex clinical scenario. We start with an elderly patient receiving a highly lipophilic medication. The patient's increased body fat acts as a reservoir for the fat-soluble drug, increasing the volume of distribution. This immediately flattens and stretches the curve. Next, we add a severe pathological stressor, acute renal impairment with reduced glomerular filtration. The resulting loss of clearance extends the biological half-life. The elimination tail arcs upward into the danger zone, indicating severe drug accumulation. Finally, we introduce the genetic variable. Sequencing reveals this patient possesses an ultra-rapid CYP polymorphism for this specific drug class. The model mathematically resolves these conflicting vectors. The massive half-life extension from renal failure pushes the concentration up, but the genetic mutation accelerating drug breakdown pulls it back down, resulting in a highly customized, counterintuitive concentration curve. Pharmacology cannot be treated as a static list of memorized drug interactions. It must be viewed as a fluid, interlocking system of variables. The outdated method of empirical trial-and-error dosing leaves patients vulnerable to these invisible physiological forces. Predictive precision medicine maps them before the first dose is given. To guarantee both safety and efficacy, today's clinicians must approach every single prescription as a highly unique, patient-specific pharmacokinetic experiment.